name is Lori Floyd. I'm making this video as part of my NU607 Advanced Health Assessment class at Jacksonville State University, where I'm an MP student. This is my volunteer that's going to help me with my video. Hi, my name is Lori. I work here at the clinic. Hey, can you tell me your name?
My name is Katie.
Hi, Katie. Can you tell me what brings you in today?
I just moved here and I just want to get a provider for my care.
Okay. Well, I'm going to do a chest, heart, and lungs assessment on you today. I may ask you to do some things for me throughout the video, such as change positions, breathe, say some words for me. Do you have any questions before we start? Okay, wash my hands, put on gloves, and close the door for privacy. So we're going to start with the posterior lateral chest. If you could turn to your side and let me see your posterior and lateral chest. I'm assessing for symmetry, work of breathing, shape, size, contour. We're going to assess for any audible sounds that we may hear, and do that posterior and laterally. So it looks like her chest rise is symmetrical, inspiration longer than expiration, no difficulty breathing. Let's turn back around to the front. I'm going to identify some landmarks while I look at Katie's anterior chest. First, we're going to have the trachea, midline, suprasternal notch. Down at the second intercostal space is the angle of Louis. We have our costal angle, which is the meeting of our sternum and costal region. And then if I could let you turn around just a little bit, I'm going to identify C7 and T1 so you can view the area with your hand. Can you bend your head forward a little bit? View the area right here, but you also palpate two prominences. The top one is C7 and the bottom one is T1. C7 and T1. Alright, so I'm going to let you turn back around. Now I'm going to inspect the anterior chest for size, shape, a normal, no barrel chest, no visible veins. The prominence of the ribs is noted. You can feel her ribs on both sides. She doesn't use accessory muscles. Accessory muscles would be your sternocleidomastoid, abdominal wall muscles. Katie doesn't require any muscles. Also with inspection, I'm going to measure anterior posterior diameter and also lateral diameter. I'm also going to count her respirations. So if you could just breathe normally for me. Okay, so Katie had about 2 respirations in 6 seconds. Times 10 is about 20 breaths per minute, which is normal. Now I'm going to measure her diameters. So I've got a ruler. I'm going to measure in centimeters. Take your arms, put them above your head. I'm going to try to get about the 4th intercostal space to get a good measurement. I'm going to measure anterior posterior. Okay, thank you. And then I'm also going to measure laterally. Perfect. And Katie's measurements are normal. The lateral chest usually is wider than the anterior posterior chest. So that concludes our inspection. Next I'm going to move to palpation. I'm going to palpate for thoracic expansion, and I'm also going to palpate for crepitus, gradient vibrations, and fremitus. So we're going to start with thoracic expansion. Can you take a deep breath for me? Perfect. My thumbs meet back in the middle. I'm going to do anterior. Take a deep breath. Symmetrical on both sides, and I'm also going to do posterior. Thoracic expansion. Alright, Katie, take a deep breath for me. Good. My thumbs meet back in the middle. Let you stay where you're at. I'm going to assess for tactile fremitus. Whenever you feel my hands on your back, could you please say the number 99? 99. 99. 99. 99. Okay, perfect. Katie had normal fremitus. Decreased or increased fremitus may indicate some kind of pathological process. Now let you turn back around for me. So I'm going to palpate for crepitus. Crepitus is trapped subcutaneous air under the skin that may be due to a pneumothorax. Can be generalized to the suprasternal area or the base of the neck, but it can also be localized, but it can also be generalized to the chest and the arms. So palpate for any crepitus. You can just breathe normal. Okay. So no crepitus noted, and then I'm going to assess for grading vibrations. Best felt on inspiration. So if you take a deep breath for me in, assess the peripheral lungs. Perfect. And there was no gradient vibrations noted that may be consistent with a pleural friction rub. So that was our palpation. Now I'm going to move on to percussion. I'm going to assess for diaphragmatic excursion and also progress the lung field. So if you'll turn around for me. What I need you to do first is to take a deep breath in and then exhale completely and hold your breath there, okay? Perfect. I'm going to percuss down Katie's back until I feel that the sound has changed from resonant to dull. Mark that with a piece of tape. Alright, you can breathe normal. Alright, this time I want you to take a deep breath in, hold it, do not exhale, okay? Percuss down her back again. Okay. Mark that area with a piece of tape. You can breathe normal. And then with my tape measure, I would measure the distance between this. 3 to 5 centimeters is normal, but the right side can sometimes be a little bit more since the placement of the liver. And then I would want to do that symmetrical also on Katie's left side. All right, Katie, stay where you're at there. I'm going to percuss Katie's posterior back. Normal being resonant. Hyperresonant sounds may indicate COPD or emphysema. Let's turn back around. And then a dull sound may indicate a consolidation such as pneumonia or pleural effusion. I'm going to percuss the anterior chest. Get down here real quick. Okay, percussion is normal resonant sound, resonant percussion noted throughout. So now we're going to move on to auscultation. I'm going to auscultate 6 areas posteriorly, 2 laterally, and 4 areas anteriorly, and let you know the part of the lung I'm auscultating. So with the trachea right here, we can start right here. This will be bronchial lung sounds. As you move out and down, we get to bronchiovesicular, and then vesicular lung sounds over the peripheral lungs. So take a few deep breaths for me, Katie. All right, I'm going to go laterally. Now I'm going to assess posteriorly. Katie's having clear breath sounds so far. Okay. You can stay where you're at, okay? You can start right there. Clear breath sounds noted throughout. No adventitious breath sounds or extra breath sounds. Adventitious sounds would be crackles or rails, which are fine crackles, coarse crackles, bronchi, wheezes, and pleural friction rub. Negative for all those. Finally, I'm going to do a vocal resonance test. Katie, if you don't care, when you feel my stethoscope touch your back, can you say the phrase Mickey Mouse for me?
Mickey Mouse, Mickey Mouse, Mickey Mouse, Mickey Mouse.
Perfect. So Katie's negative for bronchophony. The words were slightly muffled and not understandable. If I could have been able to understand that she was saying Mickey Mouse, that would have been positive for bronchophony. Now I'm going to let you say 3 letters for me, E-E-E, when you feel my stethoscope touch your back.
E-E-E, 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 E-E-E.
Perfect. So Katie, the E-E-E did sound the same. It did not sound in a different way, like ah. As if she was saying the letter A. And then finally I'm going to let you whisper the phrase Mickey Mouse. Okay, so I could barely hear. Katie was whispering something, but it was not discernible. I could not distinguish that she was saying Mickey Mouse. So she has no consolidation through our lungs, and vocal resonance was normal. So now we're going to move on to the cardiac exam. First, I'm going to start with inspection. I'm going to inspect her precordium, which is the area of the chest overlying the heart. I'm going to inspect it anteriorly from the front, and then I'm also going to let Katie lay down supine. I'm going to use some tangential lighting to get a better view. If you can lay down for me. So tangential lighting strikes surfaces at a low angle and allows you to see any kind of abnormalities across the surface. Okay. And no abnormalities noted on Katie. I'm going to go ahead and just assess her precordium while she is supine. I don't see any strange pulsations, no asymmetry. So I'll let you sit back up. Now I'm going to identify some landmarks. We've got the apex of the heart, which is the bottom of the heart. We've got our sternum, which is midline. The right side of the sternum is the right sternal border. The left side of the sternum is the left sternal border. Where the chest meets the abdomen is our epigastric area, and then bilateral on both sides we have our axilla. So I'm going to inspect her apical impulse. I'm also going to palpate her apical impulse. So with clothes off, you can usually see the apical impulse, but I'm going to palpate it right now. It's usually at the apex of the heart, 5th intercostal space, mid-clavicular line. No heaves or lifts noted, no thrills. It's less than 1 diameter. Okay, gentle 2+ pulse. So a heave or lift might indicate a more vigorous apical impulse that may be consistent with a ventricular hypertrophy. So I'll let you lay down. I'm going to palpate her apical impulse now. Put your arm up above your head for me, please. Okay, palpate apical impulse. No heaves, lifts, or thrills. Okay, perfect. I'll let you sit back up. All right, now I'm going to assess Katie's radial pulse to get a rate and a rhythm. So after about 10 seconds, Katie had about 14 beats per minute times 6, 84 beats per minute, rhythms regular. Can assess her pulses throughout her body, and I can also palpate her carotid pulse. And at a 45-degree angle, we could also assess her JVD and see if she has any jugular vein distension. So palpation was done with the palpating the apical impulse. Percussion is not very helpful in a cardiac exam unless you're identifying borders of the heart or maybe trying to attempt to determine the size of the heart. So we're going to finish up with auscultation. Auscultation is best done with the patient in 3 different positions, leaning slightly forward, supine, and left lateral recumbent. Auscultation should be done with the diaphragm and bell of the stethoscope. My stethoscope just has one side, so I'll apply deeper pressure to use the bell. The heart tones I'll be listening is the second intercostal space, right sternal border, aortic area. The pulmonic area is the second intercostal space, left sternal border. Third intercostal space, left sternal border, is our second pulmonic area, or Erb's point. Fourth intercostal space, left sternal border, is our tricuspid area. And then fifth intercostal space, midclavicular line, is our mitral area. And that's where I'll be listening to all 5 sounds with the bell and the diaphragm of my stethoscope. Just breathe normal for me. Alright, I'll let you lay down for me. I'm listening at the same areas, bell and diaphragm. Okay, Katie, and now I'm going to let you lay on your left side with your arm back behind your head so I can get you in a lateral recumbent position. Left lateral recumbent. In this area, is it good to use the bell of your stethoscope to listen for any kind of murmurs? I'm going to listen to all 5 areas with my bell and my diaphragm. Alright, Katie, I'll let you sit back up, so I'm going to talk about some heart sounds I heard and some heart sounds I didn't hear. I did hear an S1 and S2 on Katie, which is normal. S1 is the closing of the tricuspid and mitral valves. Following that, slightly louder, is S2, which is the closing of the aortic and pulmonic valves. S3 and S4 are usually abnormal but cannot not always indicate pathology. S3 is heard after S2 and can be normal in young adults, pregnant women, and S4 is heard right before S1. They're both described as gallops. And S4 can be indicative of ventricular hypertrophy, long-standing hypertension, or some kind of heart disease. Any murmurs noted would need to be described by the 8 characteristics. Katie did not have any murmurs, but the 8 characteristics would be timing and duration, intensity, pitch, quality, pattern, location, radiation, and variation between expiration and inspiration of the lungs. Do you have any questions?
No.
This concludes my exam. Thank you.